Our next session is an interactive roundtable discussion about data workforce. So we'll start with a few presentations from speakers, and then we'll have a more kind of facilitated discussion with everyone else in the room. So this roundtable will explore the current state of tribal health data workforce, gaps that exist, and strategies for how tribes can expand their capacity for health data roles. So we'll be hearing three presentations, starting with Dr. Jessica Dean, who will present on tribal data workforce gaps and opportunities from the recently completed Public Health in Indian Country Capacity Scan, also known as FIX. Dr. Dean is a Public Health Policy and Programs Manager at NIHB, so please welcome Dr. Dean.
All right. Okay. Good afternoon, everyone. Once again, my name is Jessica Dean. I'm one of our program managers here at the National Indian Health Board. I manage our capacity building efforts related to infrastructure. If you've worked with public health accreditation, you've probably seen me in those realms. So anything involving your community health assessment, strategic planning, anything of that nature. Do we have anyone that's worked with me in some of those capacities here in the room? Yeah, hi. Good to see you all. So today I'm going to be talking about our FIX report. We love acronyms here at NIHB too. So FIX for short. It's our Public Health in Indian Country Capacity Scan. We've heard a little bit about me. Going to try to keep it brief. We only have 15 minutes. So some of the things that we've already heard, I'm going to just bypass it in light of time so we can get to the good stuff. Okay, so before I begin, I just want to acknowledge a few of the members that have contributed to this report. So, of course, the tribal organizations that participated in any capacity, if you've taken a survey, if you've participated in our work groups, lent any feedback or advice, if you've been a pilot site, and also our tribal epidemiology centers, especially for the expertise and the technical assistance that we needed, our federal partners. I do want to mention that this project or this program is funded by the Centers for Disease Control and Prevention. So, of course, just want to acknowledge that we thank them for their support and funding, but any other views or things mentioned throughout this presentation is other authors, and it doesn't necessarily represent the official views of CDC. So just want to get that disclaimer out there. So what is FIX? Has anyone heard of FIX before? By show of hands? Participate in FIX in a working group? Okay. So for everyone who is new to FIX, FIX is our national assessment that we conduct just about every 3 years. Sometimes it may vary, but it's how we assess if tribes have the resources and skills they need to perform their public health services efficiently. So this is done with the hopes of getting materials and insight out to inform policies, to prepare tribes with their planning, to get them the evidence-based and the quantitative information that they need to support their initiatives. And why is FIX important? So throughout the past 2 days, I've been kind of listening to everyone's dialogue and discussions, and some of the things that you were mentioning, it speaks directly to what we try to get out of FIX. So some of the things that we've heard with respect to recognition of tribal data and sovereignty, representation in data, racial misclassification. We've heard this several times with like morbidity data, the maternal health issue that we've talked about today, invisibility in aggregate data, access, use, and contribution to relevant data sets. So FIX helps fill those gaps. And IHB has been working in this capacity since just about 2010, though we've been doing it before. We've kind of aligned those starting in 2010 through the Tribal Public Health Profile, which is available on our website. From there, we started the 2019 FIX report. We developed recommendations for not just NIHB, but for policy and other realms of public health. We've developed educational materials. So in the bottom right corner, you can see some of our issue briefs and infographics. We plan those out according to the topics that we'll go over. And then most recent report was published in December 2024. This is our cover here. So if you've seen this report, this is what we're going to be talking about today with FIX. And one of the things that was kind of different from the 2019 report to the one that we just published is going to be the inclusion of some of our COVID-19 data. So we work with Johns Hopkins to kind of redesign some of the questions to think about the services, education, our screenings that related to COVID. And we also consider recommendations for like public health authority and how it differed from 2019 to post-COVID with this recent iteration. So we administered FIX through Qualtrics. It's quite a lengthy report. For those who said they participated, I'm pretty sure you can kind of align with some of those thoughts for it being a kind of lengthy report. It's 68 questions, but within those, we do have some questions that are like check all or which apply. So you have to really take time to complete it. It's administered via computer survey through Qualtrics, but we do have opportunities for our staff to work with you one-on-one via phone to complete it, just so that we can make sure that any questions that you have are answered. If you need help working through the questions, you can get it done through the phone. You can break it up by department. You can save it. You can come back. So if there's a question that you don't have the answer for, you can always come back. We sent it out to 282 tribal health organizations, which were identified by NIHB. We received 135 responses back with a response rate of 48%, which is kind of low. We didn't actually hit our goal. Our goal was just above, I think like 217, so it's kind of low. So for that reason, we do consider this a snapshot. And even if we did reach that goal for responses, we would also consider it a snapshot and not generalizable amongst all tribes, because we know that there are different dynamics and cultures and traditions that impact all of this work and capacity for each tribe. So it would look different for everyone. So a little bit about our respondents, and I'm gonna get my notes. It's a lot of data in FIX, so I did take some notes in case we have some extra statistics that I want to add. Okay. So first you can see here the number of tribes by type. Most of them were federally recognized tribes. We did have a couple of tribal health consortiums and then 3 unidentified. We broke our regions up according to the CDC cancer map. And we did this just to make sure that the information was de-identified. You can't look and say, oh, okay, well, I think this is this tribe here, based on them being in the Albuquerque area, something like that. So we didn't use the traditional IHS map. We used the cancer map from CDC. We had 98% serving enrolled members of any federal recognized tribe, 72% serving non-federally recognized citizens. 61% of those organizations that responded served non-American Indian, Alaska Natives, and 12% served others. And for the development of the report, we break it down into 5 key areas, including public health authority. So this is going to talk about your governance structures, what types of mechanisms you're using for your partnerships, your data sharing agreements and what those look like, who is over your public health authority, so who gives the sign-offs for emergency declarations, who's able to put out or approve communications. We looked at your public health activities, so that's going to include like your screenings, your education, your diabetes, maternal health, anything that you could think of related to like chronic health and things like that. We're spreading that out through your activities. We have our public health workforce that we're going to talk about today. So who's actually conducting the activities? What does your staffing look like? Are they full-time? Are they part-time? Where do you have gaps in the services that you provide based on your expertise area, things of that nature? We also have assessment, planning, and performance management. So looking at accreditation, your evaluation, is it informal or formal? And we also take into consideration things like your core competencies, if you're using them for your job descriptions and things of that nature. And then finally, we have our public health priorities and needs. And this is basically where you're expressing what's your priorities, what do you need most from your state partners, your federal partners, and things of that nature. Okay, so let's move into talking about workforce data that's highlighted through FIX. So here we have our resources needed by tribal organizations to advance tribal public health by percentage. And this is pretty consistent with what we saw regionally and in aggregate form. So staffing, funding, and public health infrastructure were the top three things that we consistently heard, whether it was quantitative or if it was qualitative feedback. You'll see some of those common things throughout the information that we gathered. And among the top priorities for non-programmatic infrastructure building services, we have data and assessment and workforce development. So you can see that if we're looking at giving evidence base to us building out some of our strategies for workforce development, it's clear that this is a priority for at least the tribes that took the FIX report. So current status of tribal health organization analytical public health physicians needed for full workforce capacity. This is where we're basically asking tribes to think about where you are in your current state and what do you need. Thank you. What do you need in order for you to perform your activities and services at full capacity and efficiency? So when we look at our data analytic coordinators, you can see that 52%. And then also with epidemiology and statisticians, 57%, they shared that there was a need for new positions. There are also some cases where there were vacant positions. So that means that there's funding available, but we don't have the individuals with the expertise, or we don't have the people who are willing to come into the rural communities, or whatever the case may be. There's opportunities available, but we don't have the people to actually fill the seats. And then also I wanted to include this one just because of the dynamic of how we carry out a lot of our data related activities. So by show of hands, have you ever been in a position where you've worked in programming, but you also had to do data activities? Anyone? Right. So have you ever had a community health representative that's helped with your community health assessment, whether it be developing questions, actually disseminating your activities, or going out to the community with your tablets or powwows, doing your surveys there? Right. So in our roles, we have to wear many hats, right? So it's the same thing. And I just want to take that into consideration when we're thinking about our data professionals, because everyone has a hand at the table. So even in this capacity, our top full-time workforce need was going to be amongst the community health representatives. And then when we're thinking about how we're filling these gaps and how long it takes and what we can do in the meantime, most of the tribes responded stating that it takes them more than 1 month to get people in place. And it's also very difficult to get individuals into these seats that are open. So if we're in the middle of a pandemic or epidemic or whatever the case may be, when we're thinking about working to get these seats filled and continuing our services and not have to stop everything on this side and move everyone into response mode, you can think about how this could impact your ability to provide services. We also talk about workforce and FIX, training, staffing, and professional development were often expressed as a top need. And we also talk about those in response to like core competencies. We know that at least 50% of the tribes that responded don't use those for the development of their applications, for their trainings, for their professional development activities. And we use those to develop trainings to help them put those activities in place. So once again, our common themes, we heard about data access, our specialists like our epidemiologists, and then other things like emergency preparedness, programs and aids. And these are just some of the things that we collected for qualitative data, but I'm pretty sure that if you think about your current situations and where you are, you may have some common things amongst yourselves that align with what we're hearing in FIX. We kind of went over that. So one of the things that I like about FIX the most, and a lot of people ask why FIX, why you should participate, is that it's such a mutually beneficial opportunity for everyone. So on the tribal side, you're able to use this data. You actually get your data back. So it's yours. We don't keep it. We give it back to you securely. But if you need technical assistance to help you do further analysis, we can provide that. If there's a topic in FIX that you didn't really understand, we can provide training and learning opportunities. You can use it to support your funding applications. So if you need to build out a section on workforce development, we can sit down with you and pull out some of those segments on workforce development and help you provide your evidence base and your applications. You also can use it for secondary data sources. If you're pursuing accreditation, you can list FIX in your documentation. And then also your informed decision making. So your access to data and things like that. So each tribe will have access to their own data and they're able to utilize it. But on our end, we use it to inform our programmatic priorities. So we're kind of trying to get into the realm of this is our bread and butter. So when we're looking at our programs, we want to listen first. My first encounter with working with a tribal organization was in Mississippi. And as someone who wasn't a tribal citizen with that tribe, the first thing that I learned from the elders was to come in with an open mind and not assume that you know. So you have to listen and you have to step back and let them guide you. And it's the same thing with FIX. So we're here, we're listening, we want to know what's a priority for you. And this is our mechanism for doing that. And that's what we're going to use to inform our programs and our priorities, what we should be pursuing. And we're going to tailor it to our educational opportunities. If you need technical assistance, we can use FIX to support that. And also our network strategies, partners, and our trainings of that nature. We have a best practices community that we're putting together now. So some of the things that we highlighted in FIX will be included in that learning opportunity. Okay, and this is just to piggyback on some of the things that we heard about state, federal, external entity collaboration. So funding, partnership, resources, infrastructure, and tribal consultation were all listed as priorities for the tribes that responded. Especially when we think about like data access, if you have to work with the state and sometimes you're not able to get the data that you need. This is one of the things that we're strategically working to improve through FIX to demonstrate that it's a need. Okay. And then my time is up. So I just want to quickly say that we are in the process of getting our data back to the participants. We have a couple of outreach and education activities coming up. So if you'd like to participate, if you have anything that you want to contribute, we're open. We're eager to hear from you just as well. So feel free to reach out to me, come chat with me, and we can see how you can help us close some of those challenges and hurdles that we're hearing from our FIX. Okay, that's all for me. Thank you.
Thank you, Jessica. So our next speaker is Anna Wake Rose, who's Muskogee Creek, and she serves as the CEO of the American Indian Higher Education Consortium. So welcome, Anna Wake.
Thank you. I think we have somebody from AHEC here too. Izzy, hi. Hi, Izzy. This is Izzy. She's with AHEC. So first, I want to just say thank you so much for inviting us. I think what we have learned over this very long year so far is that tribal collaboration is going to be central and key as we work together collaboratively. So thank you so much for inviting AHEC. And it's so wonderful to be in a room full of health professionals again. I was able and lucky enough to be able to work with a lot of the team members here for a little while. And I have to tell you that National Indian Health Board is one of the most amazing organizations I've ever had the honor of working with. So you are in incredibly good hands. I'm very excited to be able to be here with you today. I'm also going to apologize because if you know me at all, you know this is not my skill set. Not at all. I know nothing about health data. I happen to be lucky enough to work around people that are much, much smarter than I am. And so they help me put together slides and tell me what to say. So if I get it incorrect, I will get you the right information, or I might point to Izzy and say, please help me. Because I think when you get to a place in your career that you're lucky enough to be able to work with people much, much more talented than you are, then you're privileged, and that's where I'm at. So my name is Anawake Groves. I'm the president and CEO for AHEC. Does anyone know who AHEC is? All right, we got a handful of folks. So we're the American Indian Higher Education Consortium. We represent the nation's 34 tribal colleges and universities. All of our TCUs are accredited. They're across the United States. We represent all of the federally recognized tribes are a part of our tribal colleges and universities, and we're in 16 states right now. You have seen a lot of news lately around Haskell and Sippy, and I will not let you walk out the door without asking you to call your representatives. So that will be part of my closing. We are land grant universities. We are in your communities, and we are the first stop as you think about workforce development in Indian country. And so that's why we're here to talk to you today. And I think I've got a clicker. Maybe, I don't know. I hit the wrong. Is that me? I guess that's me. Those are my slides. All right. So we wanted to talk to you a little bit about what TCUs offer and provide. Again, not a health data expert, but we wanted to make sure that you were aware as our tribes are really thinking about workforce development, as you're thinking about workforce development. And I've already asked for the slides that Jessica just provided, because just seeing the snapshot of the careers and the trajectory and the things that you all are thinking about, that's how we build partnerships and collaborations. And so these are the things that our TCU presidents are talking about all of the time. We offer a tremendous amount of degree programs within our tribal colleges and universities. 24 TCUs offer health-related programs, either an AA, an AS, a BA, or certificate programs. You can see the listing of the examples, and you can find a list of all of these on our website as well. So if you're interested in a specific program, please reach out to us and we can work on building that collaboration between you and your health center. But this is really just a snapshot. Most TCUs are two-year degree programs. For some of us, we have 4 years. We have a PhD program at Dene and Dene language and culture. So we're building and growing rapidly. If you think about the trajectory of post-secondary institutions, TCUs are actually on a little bit of the flip. You're starting to see a decrease in enrollment in a lot of post-secondaries, but we're not seeing that at TCUs. We still have a lot of first-gen students. And because our students are non-traditional, our degrees might take a little bit longer to get there, but we're increasingly building on the number of students that are attending. So now is a really good time to be talking about the future of health data and health workforce within our tribal colleges. Most of us also have a relationship with our local state institutions. And so while we might only go to a 2-year or have certificate programs, we have really good relationships with the state institutions. And so being able to build and send our students from one school to another is a key core component to ensure career trajectory and graduation. So if you're already working with a 4-year institution, please reach out, because this might be something that we can work on building career pathways for our TCUs in your vicinity and area. Our students go on to graduate programs in medicine and physical therapy, and they graduate in nursing programs. In fact, nursing has become one of the big hot topics, as you can imagine, within our TCUs. We're actually working with a lot of congressional offices right now to think about how do we build pilot programs and continue to build our nursing workforce. So don't be surprised if you hear an ask from us soon in IHB about how can we build a relationship to think about some draft legislation so that we can get some money from IHS to continue to build. And our data from our fall 2023 shows that we have about 400 students that obtained credentials in health-related fields. One of the very exciting things that AHEC provides is we call it our ACUS AIMS data system. So we oversample and sample our TCUs a lot. And I'm really excited to announce you guys are the first ones I get to talk to about this. If you go to the AHEC website, you can see a data dashboard. It's the first time we've been able to pull together and really show a good snapshot nationally of what's going on with our tribal colleges and universities. We have a small look that you can see at IPEDS, which is the National Data Clearinghouse for post-secondary. But this, right? Post-secondary or national data doesn't really tell the picture that we need within Indian country. And so we're asking questions that are relevant for us. We're talking about things like cultural programming or whether you're a mom or childcare access, or, all of these questions that really interface with our post-secondary career and a much more vibrant and realistic picture telling of who we are. So I encourage you to go to our website and take a look at the data snapshots. So our faculty initiatives. Is that the page that I'm on? Sorry, notes. All right, so it's important for our healthcare providers to be able to speak to their patients in understandably and culturally provided appropriate terms. And so one of the things that we is central to who we are as TCUs is a culturally grounded mission. Above all, Native people come to our institutions because we're community land-based institutions grounded in who we are. So our faculty are teaching from that perspective. Our students graduate from that perspective. And so as they go into the workforce, they're going to be working from that perspective. And so it's a perfect relationship for us to continue to move into IHS or to your epicenters or wherever you might need us. AHEC programs provide TCU faculty with the knowledge and skills to understand and serve their patient base in the best way possible. Programs provide insight into ways to build trust and into the communities that they serve. For example, we don't speak in terms of national statistics. Rather, we know and need to know what's going on in our communities, and our TCUs are talking and teaching and learning in that way. We do a lot of things in cooperation, as I mentioned, with national universities. And one example is the University of North Dakota. I saw Dr. Warren was in here, but he fled before I got here. I think he saw me and he was like, no, I'm not talking to Onawake. But the University of North Dakota offers a TCU faculty certificate in Indigenous public health. And that's something we've worked really hard and closely with them in the development of. And tribal data sovereignty, we don't need to talk or preach about this. It's probably what you've been talking about for 2 days, but you know this. It protects the interest of who we are as Native people and to our citizens, and it allows our tribes to govern and make decisions for themselves. And that's really central to who we are at the tribal colleges and universities. Thank you. I'm getting the hurry up, Onawake. Was that the same slide? No. Okay, look at me. I'm jumping all over the place. Oh, okay. Now I don't know what I've done at all. I should not be left in charge of the clicker. Okay. I should be on the slide where we're talking about, okay, I don't know. All right, so student opportunities. And this is where Izzy's work is and where she shines. So I should really be turning the stage over to her. But AHEC has had a long ongoing relationship with NARCH Birch, the Native American Research Center for Health, and building Indigenous research capacity. And I think we're in our second NARCH Birch grant. Thank you. And we're doing amazing work in partnership with UND. You can read the list of the work that we're doing around community-based learning and the talking circles that we're engaged in. But really what I want to talk about is our 4-week summer program that we do in partnership with UND. The first and the 4th week are offered online, and the second and the 3rd week is conducted in person at UND. And we're currently enrolling TCU students and TCU graduates. So if you know anybody that might be interested, please encourage them to reach out to us. We would really love to ensure that we get as much participation as possible. We have up to 25 participants, but I think we have room still in our enrollment. And students explore all sorts of health careers through this program, and it's something that we're looking to expand. So please talk to us if it's something that you're interested in bringing into your communities. Our TCUs enhance and supplement academic programs, and we do this in cooperation with our local clinics, hospitals, and clinical trials and shadows. So NARCH Birch is a perfect example of how we're building those partnerships across the nation. All right, so links to be able to find out more information on any of the programs that AHEC is engaged and involved in. And then I was asked to talk a little bit about gaps, and he's not holding it up another slide, so I'm going to talk real fast. I'll pull out the Okie Speak. One of the things that's important, and you all know this, is nothing about us is a one-size-fits-all approach, and tribal colleges and universities recognize this. So we're really encouraging as many of our TCUs as possible to build our relationships with our clinics, with our tribes so that we can really be the workforce feeder programs going into your communities. Our TCUs are in rural areas and housing is difficult to find. It's one of our biggest challenges to be able to house faculty and to be able to house our students. We don't have the funding for this. We're not unlike you. All of the challenges that you have within the IHS system, we're having them within the TCU system. We are all left to fight for scraps as we're trying to do what's best for our communities. And so shared approach to appropriations and storytelling is what's going to be key over these next few years. As you think about building and what's needed in your communities, reach out to us because we are your pipeline and we need to know, and we will help carry and lift and elevate those stories with you. We need more exposure for our tribal college students on the careers that you need. So I think building this relationship so that we can hear from you. I love this fixed data. We can take this to our presidents and we can talk to our presidents about what's immediately needed. And then how do we develop the degree and the certificate programs that will actually be beneficial to you? And that was as fast as I could talk. But before, please write down. I can't, my whole job, my number one job is to be an advocate. We are, as Native people, we are advocates. We don't have the luxury of not being political in our everyday lives. And so any chance that we have to talk about need, we need you right now. Our TCUs need you right now. Haskell and Sippy both lost over 25% of their workforce with the EO that required terminations. We need you to call. We need you to call. As we're talking about the need for workforce development in our small rural communities, and we lost 25% of our workforce. If you're looking at how do we build a workforce when we don't even have the faculty to be able to continue our course load, that's challenging. We are calling for you every day. We just signed on some letters from NIHB, and again, it's all about cooperation. But if you have some extra time, pick up those phones and call your representatives and say, this is not okay. Our students deserve more. And we need you to reverse the challenges and issues. So off topic, very needed. Thanks so much. Appreciate it.
So our final presenter for this session before we move into the discussion portion will be Pam Thunder, the Environmental Health Program Manager for the Ho-Chunk Nation Department of Health. So please welcome Pam.
Awesome. Well, my name is Pam Thunder. I work with the Ho-Chunk Nation Health Department. I've been with the health department for 21 years now. And I know earlier today we were talking about different roles and responsibilities and having many hats. I've had many hats over the course of that time. And I'm just going to share a little bit about some of the work that I've done in our accreditation process. And I think you'll kind of see once I get started that the information that I needed in order to move that forward was really centered around data. So we had to do something. A little bit of background, if you're not sure where the Ho-Chunk Nation is located, we're in Wisconsin. Our jurisdiction is roughly 15 counties in the state of Wisconsin. So if you take like an upside down triangle, it's the middle section of Wisconsin. We have approximately 5,376 tribal members that live in the state of Wisconsin. And then we have about 7,748 in the United States. So what makes the Ho-Chunk Nation a little bit more unique is that we're not a single land-based reservation. So it makes challenges of programming even more exciting in doing our work. So right now, the health department has roughly 220 employees, and many of the divisions and programs are very similar to other tribes. We have medical services, pharmacy, behavioral health services, quality improvement, finance, environmental health, where I'm housed, public health, community health, and health information services. So we are one of just a handful of tribes that attained public health accreditation. And at the time, I was the public health accreditation coordinator to help move us through that journey. And I've always had a lot of questions about why make all the effort? And if you've never thought about it or never kind of inquired into public health accreditation, it's a lot of work. So there has to be a very good reason why you'd want to do it in order to undertake all of that work. And it really kind of resonates with the rest of today's speakers. It's about being able to tell our story and us being the writers of that story on how we do our work. The other thing is that I recognized very early on is the way that tribal public health is done is good. And it came about when we were meeting with some of our local county and state partners, and we were talking about some of our programming and how we're connected and actually housed under the same umbrella. And our partners looked at me and they're like, I wish we could do it that way. I wish we operated that way. So in my mind, I was like, we're onto something here. This is actually a good model and we should share it. The other thing is creating a roadmap for somebody else and learning along the way and writing those things down so that the others that are going to come after me have a roadmap, if nothing else, of, oh my gosh, that did not work, so please don't try doing that, would be very helpful. I know it would have been helpful for me when I was going through the process. So it was really about that developing a roadmap and leaving something for them to be able to pick up and move along. So a little bit about our FAB journey. It started way back in 2010. So we had a little mini grant through the state of Wisconsin to kind of see where we were at, what kind of things would we need if we were really going to undertake FAB accreditation. So at that time, we went through a self-assessment to kind of work through those things. And there's a lot of things that came up during that self-assessment. We're like, ooh, these are pretty big. How are we going to be able to address them? I don't have the answers. How can I get the answers? Who has the answers? Who has the information? So those are some of the very big things that you come up to right away. And data was centered around a lot of that. And then in 2011, we decided we're going to do our first community health assessment. And if nothing else in our FAB accreditation journey, I think that was really worth it because there hadn't been a comprehensive assessment done in over 10 years. So if nothing else, it was going to be really good to see, well, what kind of services are needed by our community? We haven't really asked that question. And not just clinical services, because they were doing kind of clinical surveys as people were coming into the clinic and seeking those primary services. But there's all these other things that are going on in the health department that are just as important that weren't really getting any of that feedback. So what services and what things do our community need? So that was the first thing. But by schooling, I'm environmental health, I'm a sanitarian, I do food inspections. That's my actual training. Okay, now go do a community health assessment. Oh, okay, all right, let's figure out how Pam's gonna figure out how to do that. So quickly realizing that I needed help, I'm looking outside for the most part because my colleagues are kind of in the same boat. We're like, this isn't really what we're trained to do either. So who can we ask to help? Who are the helpers? As Mr. Rogers says, look for the helpers in your community. So I was looking for helpers anywhere, under any rock. I wanted to reach out to people. So we used for our first community health assessment, our epicenter, Great Lakes Intertribal Epicenter at the time, and reached out to them and said, hey, can you help us to develop a survey? And they did. This process, however, was really lengthy. It took us 2-3 years to get from the survey development implementation to an actual written report with things that I could actually like read. So it took a very long time with staff turnover on their end and on our end. It took a long time. Also, the implementation phase took a long time. I remember standing in our enrollment office at the desk, stuffing envelopes and surveys and putting stamps on things. Like that's how we did it back in the olden days. I know, hard to believe. So that was our first iteration of getting some sort of community health assessment completed. After we had that, we worked through getting a community health improvement plan. Also, didn't know how to write one of those either. Didn't know how to facilitate one, didn't know how. So we got to figure it out. We got to go ask people again. I was asking anyone and everyone, so how do we do this? who needs to be at the table? Let's bring those people in. We reached out to other tribes in the state. We're very fortunate. We have 2 other tribes in the state of Wisconsin that are also accredited. So I was definitely leaning in with them and finding out, well, how are you guys doing this? How does this look for you? So whatever resources we could leverage outside of the tribe, we did. Until in the back of my mind all this time, I was like, man, gosh, I wish this would be something we could do here. I wish that there was someone here that would be able to help. So this is leading into a little bit later on. So, we worked through putting together a community health improvement plan, put in our letter of intent. We had through FAB accreditation, you have to do some of the larger documents, plans, workforce development, performance management, quality improvement. Letter of intent went out in 2016. We finished our strategic plan and our branding in 2017, in 2018. And then uploaded all of our documentations in 2018. And we had our site visit in 2019. Our site visit, we already knew because so much time had elapsed between when we put in our application and uploading all of our data, our community health assessment that we originally did was actually going to be timed out. So in the midst of doing all the FAB documentation portion, I was also starting our second community health assessment. So I learned some things the first time around. So I was like, how can we maybe do this a little bit better, maybe a little easier? So coordinated a contract with UW Pop Health. So I worked with their epidemiologist to help put together that survey. We learned a lot from the first time around, and we tried to incorporate those things into the second round, but not so much so that we weren't like trying to move so far away from the first iteration to the second iteration. So that cut the time down from that 2 to 3 years to around 18 months, which I thought in like QI, that's pretty good, right? You know, you're going faster, you're getting it done. We also worked at that time with Robert Wood Johnson Foundation, Red Star, and NIHB. I did several grants kind of right after one after the other to help with people to help me write those plans, to help me put those things together, to help facilitate those things. So all of them take lots of more time than what you actually think it's going to take. But it did end up all coming together in 2019 when we had our site visit. Everything was great except for that community health assessment. So we got a work plan. Fast forward to February 2020, COVID hit, everything went on pause. So we got an automatic extension, so we had to wait. And then we actually were able to submit all of our final documentation and attain full accreditation in 2022. So along our journey, I kind of had to take you back. We had some things that happened along the way that I think were catalysts to get us there. And so I know people might think, well, what was the magic formula in order for you to get these pieces into place? There wasn't any. And a lot of it was just about timing and taking the opportunity. So if you walk away with nothing else, take the opportunity when it presents itself, would be my recommendation. We'd always done HHC accreditation for our ambulatory care facilities, so very familiar with accreditation, the language, what you need for documentation. That was not new, but some of the performance management items within AAA changed. And so we actually ended up hiring a full-time QI director, which until that time, we never really had anybody. So that was the building of that workforce. That was the beginning, is getting that separate position to help manage those things. The other thing that we recognized during that self-assessment was that communicable disease was one of the things that we identified where, how are we handling disease surveillance systems? In Wisconsin, it's called WEDS. So that's where all laboratories are reporting those communicable disease or reportables into. We were doing the same thing. We could report into those systems, but in the state of Wisconsin, the way that the software or the tool, it doesn't give primary jurisdiction to tribes. So you have to have some sort of an agreement with the local jurisdiction, county, in order for your cases to get moved to you. Before, we had personal relationships with some of our counties. Did I mention we have 15? That's a lot of relationships. FAB is really focused on formal relationships, so something in writing. So when Pam retires, somebody else will be able to pick that up. Putting things in writing. Ebola was our first one. We tried to put an MOU together with the Public Health Law Center that would help us with those communicable disease reports. And we were not successful the first time around. Then Ebola kind of showed up on our shores in the United States, and our leadership, tribal leadership, came back and said, hey, could you bring back that MOU? We're very interested. We want to know more. So that was the opportunity that presented itself. We had change in leadership. We had change in leadership of our health department. I took that opportunity when we did that change in leadership to really educate them on public health accreditation and why it would be important for our health department. I started planting some seeds then, very important, about the things that I saw as gaps when we were going through all of those processes. One, being an epidemiologist, and two, shouting out public health as a specific division, not held within another division. The other one is health board, having community actively engaged in the process, which is something that kind of fell along the wayside, but then we started that back up. COVID was the third catalyst, primarily around funding. It allowed us to have some additional resources that we maybe not would have had in order to put into place some things to help us move forward. Resources like our Ho-Chunk Nation EHR, Wisconsin Department of Health Services, Indian Health Service, CDC, Johns Hopkins, those were all areas that we were getting data from, but we really didn't know what to do with it. And so there was a lot of questions internally about how we were going to handle these things. I'm like, wouldn't it be nice if we had somebody to help us do that? And in fact, we ended up getting that epidemiologist. We ended up getting that public health director. And then the final ask was when the funding through the state came up through to get a state tribal liaison where they could help coordinate some of those boots on the ground type things. There is a tribal affairs office, but they handle everything, not specific just to health. So some of the stuff that we were able to get because we had these things in place included our completed 2024 community health assessment, our public health, environmental health annual profile report, our long COVID study, our communicable disease management vectors we're moving into enterics and food and waterborne diseases. So we're able to kind of put all of these things in place because we were able to get the resources that we needed. And it's a process and it's a journey. And did I mention I started in 2010? So don't get discouraged. Take an opportunity. If you see it, plant the seeds and help water them and maybe a little bit of fertilizer on it to make it grow. But these are just some things to think about if you are thinking about moving towards building those capacities within your organization. And I got the red stop it. So.
So much. So as we move into the discussion part of the roundtable, we can start with any questions for our speakers. Yes.
Thank you. Thank you. This is a question for Pam. You mentioned that when you tried to get the MOU for Ebola, it was not passed the first time. Like when you are trying to run these MOUs and the state says, no, we won't accept this. Can you just kind of give a brief outline of like what the issues were and what you did to correct it, or not correct it, but what did you do so that it would
Yeah,
pass?
so actually the MOU was in the bump or the hurdle that we had was actually on the tribal side, getting our legislators to sign that. And we worked with the Public Health Law Center from Hamline University in Minnesota to kind of put some of that language together. And there was just some things in some of the language that they weren't comfortable with when we initially took it to them. They're like, I don't know. It was very formal. So it's like putting that formal relationship, government relationship, so that the state and the counties would then be able to like they would have to share that information. And then the other part of that is that, and I think it was the part that we fixed when we went the second time, was that if we don't have the capacity to do it, you are required to assist us. So it's a two-way street. It's not just a one-way street that you also have some obligation. Like there's a part for you as well. So I think when we changed a little bit, but it was the Ebola coming here where tribal leadership was like, I think we really want to reconsider that, or I think there's maybe room there for some sort of an agreement. But then that helped us. I think we have 6 MOUs right now. We would like to get kind of our largest 8. That's our goal. But I think that was the issue.
Other questions? Yeah, Colin.
Hi, thanks everybody. This is Colin Gerber from CSTE again. Sorry, another question for you, Pam. Did you, following the accreditation, did you notice any difference in kind of your dealings with any of the counties or state departments of health?
Yeah, I think engagement is probably the biggest change that has been. There's been, I think, much better engagement. And we have, and it varies. So some of the counties that we have relationships with are great. Others, maybe not so much. And I think the issue that we struggle with now, along with a lot of other organizations, is the turnover on both their end and on our end. So it's about constant education and letting and re-educating. But I do think that the engagement has definitely been more meaningful on both parties. And I think part of that is just the traumatic COVID experience that we all went through together. Like that trauma, I think, was part of that bringing it together.
Other questions for speakers?
Programs, we know that to help build up the workforce, we need to be thinking about this.
Yeah, I'm not sure if there's something that's already in existence. For my role with accreditation, I can say that we've tried to implement some of those very principles into the way that we conduct learning communities so that it's more beneficial and it's tailored to what tribes are expressing that they need. So for example, with workforce development, we'll bring in national organizations that can provide that foundational knowledge from the national standpoint, if there are any toolkits, if there are any resources that are out there. But we always make sure that we bring in a different tribe that's already worked through the challenges, through the hurdles. They can provide practical examples. They can lead you and help you navigate certain scenarios that they know you'll encounter. So with workforce development, we've partnered with like the Public Health Foundation, where they've gone over the core competencies, what it looks like to develop a workforce development plan. And then we brought in Winnebago Tribal Nebraska to show tribes what it looks like from their perspective to work through putting those together. And we don't have a recognition program. We're very grateful for everyone that partners with us, especially tribes, because we know you guys are doing a lot of work. But we do try to make sure that we recognize them. We do health reporters where we're acknowledging the great work that they do. We publish those for our national conferences. But I would love to see something along the lines where we can highlight the great work that's going on. I think a lot of times we look at the deficits and that can become the main point, but we know that the work is already going on. It may be under a different name, it may be under a different title, but we know that the people that are receiving the services are getting the help that they need, they're getting the resources that they need, and it's because of everyone just like you that's doing the great work. So I would love to see something along the lines of that.
Ditto to everything Jessica said. I think that's exactly right. I don't know of a certificate program or anything that's focused specifically on that, but I think all of our TCs would be interested in what does that mean. We also have a brand new tribal college in California. So California Indian Nations College, I would request that you reach out to them and talk to them. They're recruiting tribal students and tribal community members from across the state to attend right now. It's a 2-year institution in partnership with UC Riverside. So they would be, I think, a really good resource for you as you're thinking this through.
So now we get to move into the part where all of you get to join the discussion too. So at your tables, you can discuss at your table some of these questions that we have. So kind of starting off looking at what kinds of challenges have you encountered in wherever you're working? So if you're from a tribe or a tech, are you facing challenges in data workforce recruitment, retention, or professional development? If you're from a national organization, what kinds of trends have you noticed about where the biggest workforce related challenges are? So you can kind of discuss that at your tables for about 12 minutes, and then we can come back and share with the group and have kind of a larger discussion. And I would invite our speakers to join tables and join part of that discussion too. So thank you. Okay, if I could get your attention back, come back to the big group. Would love to hear some of what came out of your conversations. You can't hear me. Thanks, Chris. Okay, so it sounds like there's some really good conversations going on around the room. Love to hear what some of those were. If anybody wants to share with the bigger group, kind of what were some of the big themes that you heard come out of those conversations about data workforce challenges that your different folks have been encountering? Anybody want to share some of kind of the takeaways of what you were hearing? Anybody? Yeah, please. Yeah.
Hello. So I work for a state health department, and I am not a member of a tribe. And one challenge that I've noticed working in state public health is that there are very few of us epidemiologists who are aware of how to work with tribes, who have that interest in that will, and even have opportunities like this to learn and figure out how do we do better, how do we help to really bridge that gap. So that's one workforce challenge, because I noticed when looking at the data about the need for more data scientists or epidemiologists and biostatisticians, and that not necessarily merging with the training that is available. I think many of the epidemiologists could be, I don't want to say co-opted, but kind of introduced to working with tribal data. And I mean, it's our job, literally. So I think that's a challenge and an opportunity.
Mm-hmm. Did anybody else's conversations kind of touch on that idea of even when there are maybe people with expertise available, they're not familiar with tribes? Or do you want to share any from this table?
So yeah, I'm from the Lumbee tribe in North Carolina. So we have a large number of programs that are even internationally known for their public health work. And so when we reach out to them and start talking about working with us and data sharing and some of our things, it's like, oh, well, we know how to do it all over the world. We really don't need to hear from you how you want your information done and work done. So we, in our tribe, we have a large number of nurses and physicians and pharmacists, professionals. And so we're now just trying to work with our university, which was not a tribal college, but it's established in 1887 by American Indians for American Indians, and trying to get them now to work so that we can develop pathways to researchers who are tribal members or have done that. So what we've decided to do is, even before someone starts becoming reaches out to us for a clinical practice, because they all want to do that. So it was like, okay, then you have got to have complete this module, which the tribe is creating. And you have got to work with the tribe some yourself, even the faculty, before we even let your students begin.
Thank you. Anyone else have conversations about like gaps in cultural competency or another theme that you want to share? Like, what kinds of challenges or trends have you noticed or encountered? Yeah, Colin, go ahead.
Yeah, thanks. One thing we spoke about at our table a little bit is I talked about how CSTE has been making an effort to try and expand its applied epi fellowship to include more tribal host sites and get more fellows, both from tribal communities and applying to work in tribal sites, but noting that, the fellowship is not intended as a tribal program, and is intended more as like epidemiology kind of writ large. So it's not tailored necessarily for those contexts. And we talked about how, for tribes and tribal health organizations, they're kind of end up sort of stuck a little bit between this rock and a hard place where, you can try and stay within those programs that are more culturally appropriate, that are more tailored for your nation, your context, but are maybe chronically underfunded, as we frequently talked about. Or you can try to, go out and compete in like the broader field for these programs that are, more context agnostic, that, maybe aren't tailored for this environment, where organizations might be competing at a structural disadvantage because these programs, these funding mechanisms were not built with tribes or tribal health organizations in mind. And so it's kind of constantly needing to strike that balance where, yes, there might be these, vast pools of funds that are out there, but that come loaded with all of these additional challenges that might require, needing to apply competitively every single year to get those funds again. Whereas like the funds that might be, a little bit more consistent, that, are more available, might not be sufficient to meet the need that's there. And that was where kind of our discussion was focused on.
Thanks. Okay. Another table want to share kind of some of your takeaways, interesting things that you discussed. Hi. Feeling a little quiet in this afternoon? Yeah, please. Yeah, go ahead.
Okay, I'm coming from the other opposite end. So I'm Jordan. I am with Indian Country Today, so I'm an editor. I'm just here learning. But at least what I found, at least in our indigenous journalism, is that there's a lack of like health reporters who really understand data and also the nuance of how to tell a story and use it as a tool to tell a holistic story, especially when it comes to policy and politics. And also, I think with non-native journalists, it's also very something I take. I guess like try not to share too much with them because I know they could weaponize it against our people. So I guess trying to balance those two. Indigenous journalists who can't have that background. And I only know it because I was in sports medicine before I got into here. And so I take tons of stats classes. But yeah, I guess that was just something I didn't share with my table, but just thinking about and hearing everyone talk.
Thanks. Yeah, it's a really interesting perspective. Yeah. Jessica, do you want to share anything from your table that I can call you out? Go ahead. Yeah. Go ahead. Yeah.
So you're talking about the cultural competence. So I am from Montana. I am part of Rocky Boy Chippewa Cree. And I work for a place called Prevention Support Services, and I provide technical assistance to prevention specialists who provide substance misuse prevention on tribal lands. And when I first started, we call us technical assistants, so TAs. We had only 5 regions, and then we found out that we needed to be more culturally competent to those prevention specialists on tribal lands. And I became that tribal TA. And I actually was just telling the table that I don't really have a lot of, they're not my prevention specialists. I call them that because I feel like we have a really good bond, but I don't hire. I'm just there as, anything that they need. But in a lot of the other regions of prevention in Montana, they have turnover, and I have actually not had a lot of turnover. And if I do, they usually go on to like other prevention jobs that in other like tobacco or school or whatever the case may be. And I think that's because we do provide that culturally competent TA to them. Or either I'm very lucky that it in Montana. So I just want to say, like, we saw that need and then filled it. And I work for a nonprofit. I get funded through like grants. So the tribes don't pay me. I'm just there to help them and really just meeting them where they are and what they need. And it's been a really positive experience. And I know, like, talking to everyone at the table, I'm very lucky that I don't have that kind of turnover. But another thing that we talked about is in Montana, to be a certified prevention specialist, you don't have to have like a bachelor's degree or even an associate degree. So that is an extra, barrier that's taken away. So if you just want to come in, I will teach you how to do prevention and help you along the way. And I think that's really helped move prevention forward in Montana.
Thank you. Yeah.
Jessica Perfett from the National Center. I think part of our table conversation too is looking at the staffing shortages that we see, at least at a national level. It's hard. A lot of people get into public health and don't really leave public health. They'll go into different areas or leave their role to go fulfill another role. So being the TA center, providing that support and the funding and the resources that's free of charge to them and kind of more on our dime has been really helpful in bridging that gap. But that's something that we have seen on the national level. It always comes down to staffing and funding.
Any other tables want to share a little? Okay, so then the next question to discuss among your table is about kind of what do we do about it. So we've heard a lot from the speakers and from several of the the tables about the importance of partnerships and a lot of the kind of possibilities that are potentially out there. Some of them explored, maybe there's more exploration to do. So if there's a chance to talk with your table about what partnerships your organization has leveraged to support data workforce capacity, or what new partnerships are you thinking about that maybe you could explore. So you can go ahead and have another 10 minutes or so to discuss with your table.
Would anyone like to share from their table anything they've discussed that might be beneficial to the group as a whole? Our speaker, Jessica Dean, Dr. Dean.
Yes, so I haven't had an opportunity to engage with the table that I'm at yet, but I do want to do a shameless plug for Fix. So the question about what new partnerships could your organization explore that could help you with data workforce. By show of hands, if you are in a field where you provide training for Excel, SPSS, SAS, or anything like that, can you raise your hand, please? Yes, I see a couple hands. If you provide any foundational education opportunities related to data, workforce, or anything of that nature, can you raise your hands? Okay, so everyone that's raising your hand, I would love to partner with you for Fix or educational opportunities. I'm looking for new partners. I would love to learn about your organization. So after our meeting today, please, please, please follow up with me so that we can build out some of those things that we're looking for our learning communities for best practices, and then also for our public health accreditation learning community as well. So thank you.
Thank you. Thank you.